Good morning, everybody. Welcome to this combined session of the Society of Critical Care Medicine, the American College of Emergency Physicians, the CDC, and the IDSA. I'm really excited about this because we're going to talk about a topic that's becoming more and more important. As most of you know, through the Surviving Sepsis campaign, we produced sepsis performance metrics, which have now been adopted nationally by CMS, that really mandates rapid institution of appropriate antibiotics for all patients suspected of sepsis within the first hour. And that's based on data that clearly show that for every hour delay in receiving antibiotics, the odds ratio of mortality goes up. So that's the kind of good news. But of course, the bad news is we live in a time of serious concerns about antibiotic resistance. And you can say that, and many people do, that the performance measures, which are now adopted nationally, may have unintended deleterious consequences by driving antibiotics into patients who turn out later not to have had infections. And that's often been used as the reason not to adhere to or accept the performance measures. And over the last, I'd say, year, 2 years, the Society of Critical Care Medicine has formed a partnership, in particular with the CDC, but also very closely with the ACEP and the IDSA to address this issue. And really the way we've come to see how to balance this is by marrying the rapid institution of appropriate antibiotics with rigorous antibiotic stewardship. And that's what this session is about today, to really talk about how we can make the drive to get early antibiotics effective while not or minimizing how long we give antibiotics and the population to which we give antibiotics. And that's why I think it's appropriate to have our panelists today. And I'm looking forward to this discussion. And as we introduce the panelists, I also want you to think of yourself as the fourth panelist, because we're going to go through 3 questions. And at the end of each question, half of the answers will come from the panel, and hopefully the other half will come from all of you. So we have mics in the front, and I think we have one in the back. So please feel free to join us and ask questions. I'm going to introduce the panelists. In fact, I'll let each panelist introduce themselves and say a little bit about the work that you're doing.
Thank you. So my name is Lauren Epstein. I am an infectious disease physician at CDC, and I work in the Division of Healthcare Quality Promotion. And then I've been working on sepsis initiatives within the division, and I also work on trying to assess antibiotic appropriateness.
My name is Tiffany Osborn, and I'm with the American College of Emergency Physicians, but also SCCM. Half my time is in the emergency department, and half my clinical time is in the surgical trauma intensive care unit, and I'm a full professor at Washington University.
And I'm Stephen Weber. I'm a Chief Medical Officer and Infectious Disease Faculty Member at the University of Chicago Medicine. I ran the infection control program there for about a decade, and I serve with IDSA as their liaison to the HICPAC committee.
Okay. So I've already mentioned these objectives in my introduction, so I want to, in the interest of time, get right to the questions. Okay, so this, as I said, we're going to go through 3 questions. Each of the panelists will say a few things. Hopefully I'll get them to argue with each other a little bit. And we're going to take, I think, about 12 minutes per session, question, maybe 20 minutes per question, half of which the panelists will do, and half of which I hope you'll stand up and argue and debate and so on. So can we start with the first question, which is, are the goals of integrating antibiotic stewardship with the rapid treatment of severe sepsis and septic shock, the SEP1 initiative, mutually exclusive? And I don't know if anyone wants to start first, but...
Okay, I'll bite. So I would say that they're not mutually exclusive, but I would say that with a caveat. So clearly, the eroding antimicrobial patterns of susceptibility are outpacing, novel antimicrobial design. And the ASPs are very important. And they generally fall into 2 domains. So one domain is auditing, so either prospective auditing at the point of order entry or a retrospective auditing within the next 12 to 24 hours. And the second domain involves formulary restriction and pre-authorization. And I would say if your ASP falls within that category of formulary restriction, then I think that has the potential to create challenges in some aspects of meeting the measure. If you are prospective and with an auditing, then I think that you have the benefit of having meeting two goals, one being appropriate antibiotics, and the other being meeting the SEP1 measure.
You know, I think we're going to agree more than we disagree. We probably have more differences in wardrobe selection this morning than we do in terms of our differences on this. But as I would take a little bit different or add on to that view a bit, because and you run the risk of undermining the premise of the session, because I think the question as stated isn't even really legitimate to me, because the reality is when we take a view that's overly simplistic of antimicrobial stewardship, which some folks will use synonymous with antibiotic restriction or cost reduction, then you could see this being a legitimate question, a legitimate issue. But fundamentally, antimicrobial stewardship in 2017 is a basis of judicious antibiotic use, not restriction. Where judicious is the right antibiotic, the right time, and the right dose for the right patient at the right duration. When stated in that way, you come to a conclusion that it's not a matter of restricting, although I agree with this kind of conventional notion of the antibiotic police. But you look to say, well, the product of a robust antibiotic stewardship program may, in some patients and populations, be added antimicrobial coverage or refined antimicrobial coverage, and in others it might be less. To the folks who say, well, that undermines the notion of stewardship as an expense reduction tool, I can put on my C-suite hat and say, no, it absolutely doesn't, because fundamentally judicious antibiotic use, even if it's higher direct cost of antibiotics at the beginning of therapy, still will produce economic benefits by avoiding the complications coming from underutilization, underprescribing, or in the case of overuse, the idea of toxicity. So I think holistically when we look at it, I agree with what Tiffany said, but I would just add to a broader view, which I hope can convince this group that the two don't need to be in opposition.
And I agree. I think that when a lot of people hear antimicrobial stewardship, they hear do not give antibiotics or stewardship is impeding antibiotics. And I don't think that's the message at all. I think the message should be optimized treatment and while reducing any adverse events of antibiotics. And it's not to give antibiotics. Actually, some stewardship programs actually facilitate early antibiotics and giving antibiotics. So I completely agree. And I think that just to also add is that there's no right way to do an antimicrobial stewardship program. I think it depends on the resources available and whether or not and how that's done really depends on the facility. So many facilities may not be doing a restrictive antibiotics, and just to put that out there too. But again, I really think it's a way to optimize antimicrobial use and really to provide an infrastructure to support clinicians in making good choices about antibiotics.
So let me start the discussion off. I'm going to direct this to you, Steve, as a IDSA who should be the guardians of antibiotics. How can you use the word restrictive and at the same time ask clinicians, especially emergency department clinicians, to just give antibiotics wildly to anybody who's suspected of sepsis within an hour? I mean, essentially that means that if you're in the ED and you have any suggestion or any thought that someone's septic, someone with bilateral infiltrates who has an EF of 10%, basically you're saying give antibiotics right away, immediately. How could that be judicious?
I think it's unfair to say that's basically what I'm saying. I think I am a little bit, and you touch on this, a little bit of an infection prevention stewardship libertarian, wherein at the organizational level you can often make decisions, those who were here from the last presentation, looking at local epidemiology in a dynamic way to arrive at some guardrails around it. Because, and I think we'll come to this a little bit later on, if we leave antimicrobial selection to the moment in time when we're all first evaluating a patient, no matter the experience, the expertise of a given clinician, we're probably doing something wrong. So there's some broader guardrails we can put around that say these are the populations who might be eligible for that kind of broad approach. Stepping back, though, we'd also remember, too, that certainly for this audience and this subject, that approach sounds alarming. On any given day, even that scenario you describe is probably not the biggest misuse of antibiotic going on in that institution in that moment, particularly if you include primary care clinics, pediatric clinics, even infectious disease practices. So I think looking holistically, there are places where we're going to be able to restrict and reduce unnecessary antibiotic use. And then there are going to be other places where we might be more liberal. And I would just argue that this is probably a place where the cost of being wrong with restrictive policy is far greater than it would be in some of the other settings I mentioned.
That's
Good
great.
point. Good point.
Questions? Discussion? Please feel free. Great. Just let us know who you are and where you're from.
My name's Amber Miller. I'm a clinical pharmacist with Antelope Valley Hospital. I just had a quick question for you when you're talking about the design of your antimicrobial stewardship program being prospective and trying to marry that at a community hospital with getting those antibiotics in within an hour. How do you make those two work in a community setting where you necessarily don't have an attending on call 24 hours a day?
So that is a great question and actually gets into one of our next questions, I think. But it's a great question. And I think that where that comes into play is creating antibiotic order sets that have multi-stakeholder involvement. So you've involved ID, you've involved pharmacy, you've involved the emergency department. And you create those order sets in a way that the clinicians use them. You make them user-friendly. And we found that to be associated with organ system. So they go in, and all of the options within each organ system that may be associated with that infection have already been approved by this multi-stakeholder group. So it provides an effective, standardized way of giving clinicians effective choices, whether it's 2 a.m. or 2 p.m.
Great. Thank you.
I would also just add that that's why this provides the opportunity for performance improvement, because we know that the most effective technique for performance improvement is audit and feedback. So if you track the time in your institution that it takes to get those antibiotics in and see that the biggest gap is between the order and administration, you actually have a target to aim for that can improve.
John Mazuski from Washington University in St. Louis. I'd like to sort of extend a little bit Dr. Levy's comments. I mean, to me, the Achilles heel of trying to be good stewards of antibiotics and meeting the surviving sepsis is the issue of exactly the patient comes in the ED, it's an elderly patient with a decrease in mental status. Who knows what their diagnosis? Now, post hoc, we say, oh, it was sepsis, and you had to meet this criteria. But when the practitioner is faced with that, the hour, how are we going to be judged? We want to be good stewards. We don't want to overtreat the patient, and yet to realistically arrive at that first definition of sepsis, which is infection with the presence of these things, is really a very difficult process. And I don't know if there's any solutions or how are we going to attack that problem.
I realize that that's very complicated. I think we've all run into that situation. And I think that one of the ways you can look at it, too, is that that's a way to reinforce reevaluating antibiotics. So if you have to give antibiotics and a clinician thinks that it's appropriate initially and you think that it's a septic patient, but you're reevaluating. So looking at that patient within 24 hours, 48 hours, and reevaluating if they still need antibiotics, I think is a crucial part of stewardship, and figuring out maybe they actually got the first dose, but then the next day they didn't need it anymore. Just making sure that you're reevaluating it. It doesn't stay on for days at a time, especially if you found the source of their infection or you find out that they're not infected.
And just to build on that, with John actually is the current president of the Surgical Infection Society. But to build on what you said, one of the other things that's really helpful is if you have rapid viral detection system. And when I say rapid, when you're talking about an emergency department, that doesn't mean 6 hours. That means within the hour. And the clinical effectiveness of some of those is a little bit variable. So that's one area that can help if we can rapidly identify what's virus, what's not. And if we can't get it rapidly, at least send it off so that the group who is taking the patient will be able to determine actually this is a virally induced and can take the antibiotics off and treat them appropriately.
So let me pursue that question a little bit more, and this is for you, Steve, I think. So the concern that's often voiced about the measure for rapid antibiotics, the data that are pointed to are the data that arose from the pneumonia initiative, and that there was published in the annals, and I'm going to forget the lead authors, but basically showed that about 20% of the people who received antibiotics turned out not to be infected. So let me ask you, if this is successful, and I think CMS is going to make sure that people are compliant, and of getting the antibiotics. Tell me what you think. What are the deleterious effect of getting a single dose of antibiotic if you marry it very quickly with stewardship?
Well, I think to the question, the deleterious, you're measuring then the deleterious versus the potentially advantageous approach of that first antibiotic. And we know we have good literature on the latter, of getting the right antibiotic in on time. I think in all likelihood, as was the case with the pneumonia guidelines, pay for performance around that, we will see some patients getting the wrong or additional antibiotics. And the reality is, are we willing to, as a broader society, to accept that risk? It's interesting because you look at the guidelines as they're written right now. Virtually any guideline is fundamentally built around the notion of from the perspective of the patient. What's never really clear as you look at that, is it from that patient alone or all patients, which is where stewardship comes to bear. I think that we will probably end up accepting some broadening of what folks are getting at the outset. I think in many ways, some would argue it will be less than what we saw with the pneumonia guidelines. I'd be interested for your perspective on that. But at the end of the day, the benefit will come, as my colleagues have said here, from that close follow-up and understanding what happens on day 2 and day 3. The idea of antimicrobial inertia is a real problem, and it's understandable that somebody at that first point of contact, whether in emergency medicine or elsewhere, might go broad in terms of the coverage. The real responsibility comes in going forward from that point. There probably is some deleterious effect of that initial dose, but where there's a real accumulating aggregation of risk comes with ongoing unnecessary doses. And I think that becomes a first and early target. I think it's going to be very interesting because the competing guidelines, right, are, for the first time ever, we now have CMS conditions of participation around just simply having an antimicrobial stewardship program. As things evolve and we see perhaps that becoming a forcing function for more resources and a broader application of stewardship, perhaps we'll see some more meaningful tools to direct us to a solution to that. But for right now, this may just be the society we live in.
Great. Any other comments? Dr. Howell, I see you there. Would you like to make a comment? I told you you guys were the 4th panelist.
No, thank you. No, I think the point that stewardship is not restriction, that stewardship is the right antibiotic at the right time for the right patient as soon as the need is recognized is the right point from this. And I think the point that this is this is a great question for a panel, but it's a difficult question for a clinician who's there at 3 in the morning trying to understand what to do. And I think if there's one take home from my standpoint, it's treat early, treat correctly, and reevaluate every single day.
Yeah, that's exactly right. I always wonder, just give the antibiotic.
Right.
Just give it. I mean, that was my point about you give one dose of an antibiotic. I mean, all of us who are on rounds, our house staff give antibiotics in the middle of the night. We're never critical of ever giving antibiotics. We just say, okay, now what do you want to do? And I fail to understand the argument about not giving antibiotics. If you really marry it and you say in the morning, you're going to say,
that's right.
Right? And I feel a lot of times we're just in an academic argument rather than a clinical argument.
Hi, Mark Hamill, Carillion Clinic in Roanoke, Virginia. Just had a question regarding, almost de-escalation in some situations. We often have little debates going on between services. Person with a infiltrate on a chest X-ray, worsening pulmonary status, treated for, what is clinically a pneumonia, and, with cultures that may show something. All right, and our infectious disease people, if they're involved, it's often, oh, well, it's probably colonization. They probably don't have a pneumonia. You can stop the antibiotics. How do you decide who's right there? And are you hurting the patient by making the wrong decision? And, if you're while de-escalation is a good thing, when you have situations like that, where do you go?
That's going to be our 3rd question, by the way, but
I think that a lot of people get into and this is always a problem coming from the emergency room or giving an antibiotic in the middle of the night and kind of goes along with their question. I think when you get started on antibiotics, someone starts in the middle of the night and someone starts in the ER, you kind of start that trajectory of keeping someone on antibiotics. Because when a patient's doing well, you don't want to stop antibiotics. And when a patient's doing worse, you don't want to stop antibiotics. That trajectory. So I think that it's not just, it's kind of evaluating the whole situation, and ID doctors love to say, oh, it's just colonization and you can stop the antibiotics. But I think you have to take the context of the whole patient and not just say there's an infiltrate, that we see an organism. Just because you recover an organism doesn't mean that someone is necessarily infected. And I think that you can look at the clinical context of the patient and say, they're in the hospital, we're monitoring them, they've received antibiotics, they seem to be doing better. We can stop antibiotics because essentially fighting an infection, a patient fighting an infection isn't just dependent on them getting antibiotics. So I don't think if a patient if it seems clinically reasonable, I don't think that there's any reason to keep going with antibiotics if you think that it seems you can stop and you're still watching the patient. I don't think it's unreasonable to stop.
You hit in your question kind of the key point, which sometimes is overlooked too often, I think, because we tend to prefix or put at the end of the phrase, assuming the patient is doing better. And we never, ever want to lose sight of that, because if there's still question, then we don't even want to entertain that consideration in my mind. In fact, we may look to broadening the therapy. One thing that becomes, I think, a useful exercise I take our fellows and some of our folks through is the notion of it's a harder decision to stop antibiotics for where we're at. But would we start antibiotics at this point? If the situation were different, would we feel, and it just challenges the mind a little bit to think about it. But it is a matter of interpreting those other results with caution. So the urgency of early cultures and non-culture methods to determine pathogen weigh so much higher than the samples that are collected on day 2 and day 3 and day 4, because we know, for example, that if someone's been getting assaulted with piptazo or carbapenem for a couple of days, what will come from a tracheal aspirate will almost certainly be resistant to those kinds of strains. It will either be a yeast or it will be a stenotrophomonas, something like that. And to that end, that can be unsettling and misleading. Of course, if the patient's doing better, then I feel a lot better telling the team it's colonization. If the patient's looking worse, then I think it's foolish to do so.
I always have the problem of what does looking better mean, right? What's the clinical definition of looking better? And I was listening to our very esteemed and knowledgeable colleagues yesterday, Lena Napolitano and Henry Massour, and it was nice to hear them discuss something that I typically employ when I'm in the ICU, which is looking better to them was, okay, well, the patient is defervescing, the white count's coming down, the trend is in the right direction, then you can consider stopping antibiotics. If it's anything else, as you pointed out quite effectively, then you don't.
I guess part of my question comes down to what you said was that who decides what's clinically reasonable? And you can have very differing opinions on that. And if you're going to have something that might end up being having some teeth to it down the line, a guideline, who decides what's clinically reasonable?
It does speak, though, to having these debates not around an individual patient where there's apt to be considerable variability and uncertainty, but to the point that's been made already, these are discussions better made in a conference room than at the bedside. And I don't think we give it that attention because there is an opportunity. We become really pretty good as specialties at determining signs of clinical progression, of worsening, and yet the attention we've given to your point about really delineating what are the signs of improvement. But again, to try to decide that on the fly, in a room, family around you, worried staff, worried team, it's almost impossible to not see some degree of variation in that setting. So fair.
Jordan Kempker from Emory. Back to the question, with one of the goals of stewardship to be to reduce resistance, do we think SEP1 will lead to more broader spectrum antibiotics given for flimsier indications for shorter durations to potentially lead towards more resistance?
So I hope not.
I agree.
I hope not. But I think that when you look at the population that the federal regulations or the federal program is trying to target, it's severe sepsis and septic shock. These are patients that we already know are in duress, and we think that they're in duress because of infection. So that's different than having someone who just has an infection. Do you see what I mean? So I would hope that if we're targeting the right population, that we would be less likely to see that.
So I just want to, that's a great question, the what if. And obviously with the Surviving Sepsis campaign, I've heard what if for about 16 years. And the problem with what if is we stop everything because of what if. And if you look at the example of early goal-directed therapy, there was what if. What if it turns out to be negative? What if? And the what if turns out there was no difference. The what if never turned out to be early goal-directed therapy is more harmful than usual care. It's just no different. So in the case of early goal-directed therapy, where everybody was screaming, the sky's falling, this is terrible, we've adopted this, it turns out that there was some unnecessary central lines placed, but even in the 3 large trials, there was no difference in outcomes. No evidence of harm at all in early goal-directed therapy. So the what if there turned out to not be the case. In the same way that we just have to wait and see. We think the risk-benefit ratio favors aggressive antibiotics, but we don't know. But the data are certainly supportive of taking a chance. And
Do you mind if I add to that?
Please.
So being the trial clinician for PROMISE, which is one of the things that we have to remember with that is that all 3 of those trials required 4 things before you ever entered the trial, before you could be randomized. You had to have had early IV fluids, early antibiotics, early lactate measurement, early blood cultures. So those were things that had to be started before, actually I guess it was IV fluids, antibiotics, and cultures. Lactate. So you had to have all 3 of those before you were even considered to be randomized. So if your system isn't doing that to begin with, then you may not have the same results. But early antibiotics was part of what had to be initiated prior to even being considered in the trial.
One last question, and then I want to move on to the other question.
I think that is a really important point. Even looking at administrative data where we see the rates of sepsis are going up and mortality is going down, and is it a question of better recognition, or are we identifying patients that are less sick? And it is a question if for some reason patients that may be less sick may be getting really broad spectrum antibiotics. I think that is an important question to think about, but I think we're all agreeing that we don't know what's going to happen. Yeah. So.
One more?
Yep.
Sorry.
Hi, Ryan Mabes. I'm an intensivist in San Diego. I'm also actually an ID fellowship director, so being kind of on both ends of this, it's, speaking for my tribe, we get it. It's a challenge to know what to give someone that first hour. I think probably one of the practical things as an intensivist people fail to do is set themselves up for success. You mentioned blood cultures up front. Sporadically performed, right? Relatively sporadically in very high functioning institutions. I will occasionally, when I'm consulting on ID, be called for someone who has been on meropenem and still febrile for 14 days. And my favorite thing to write a note is if someone is not better with 14 days of a carbapenem, what they have is not treated with the carbapenem, right? Yeah. One of my former fellows put it, I think, beautifully. Antibiotics are not magic, right? For example, in a young, relatively healthy population, if you have a young person with unexplained sepsis, almost certainly that is a ceftriaxone deficiency disease, occasionally staph. The other things that so that person is unlikely to benefit from the carbapenem. That's not to say that it's wrong to give it up front, right? It's not to say it's wrong. You have incomplete data. You don't know if that guy just came back from India and is swarming with NDM in their bowel. But the failure to set ourselves up for success with this, right? Getting early specimens and then hitting people with whatever therapy you need, and then stepping back, and believing your cultures, at least not with every isolate, but with some isolates, like staph will grow. Staph aureus will grow. If it's there, it will come. So 48 hours later, you're not growing staph. Probably don't need vancomycin. These are fairly small focal steps, and I think we tend to kind of rend our garments and gnash our teeth a little excessively, when the truth is, when I'm admitting someone, when I'm ICU attending in the first hour, I will drop the bomb on them, but set yourself up for success at that 48-hour point. And then a lot of these conflicts become not that big a deal, right? Not that big a deal. Just an observation. Thank you.
Thank you, and I'd like to move on to the next question. I would like the record to show that an infectious disease physician just acknowledged that antibiotics are not magic. So
I'll be going now.
So the next question is, how do you balance rapid antibiotic choices to select the best antibiotic while still protecting members of the community from further development of antimicrobial resistance? And then the second part of that, how does a thorough understanding of infection and antimicrobial resistance impact clinical practice?
Okay. I thought you were pointing at me. Were you pointing at Steve?
No, whoever.
I'll go.
Go ahead.
Yeah.
So I think it's important to note the first thing about stewardship is that it's really it's a patient safety. It's focused on patient safety. So I think any clinician, when you're looking at a patient that's sick, whether it's a diagnostic test or you're thinking about antibiotics or procedure, you're focused on that patient. And it's hard to put the community benefits or the hospital benefits in the context of treating that patient. But I think that thinking about stewardship, if you're appropriately treating patients, if you're thinking about antibiotics, if you're thinking about shortening the duration and you're keeping this in mind when you're treating patients, I think that will impact society in a positive way by just treating the patient in the best way possible and using available evidence and using stewardship to limit duration and make sure that you're dosing appropriately and you're treating appropriately for infections. And the second thing I wanted to point out is that I want to point out that stewardship really provides the infrastructure for success in treating patients successfully. And I think if we think about it that way and the way that we think about infection control programs, an infection control program isn't necessarily going to decide who gets a central line and how long that central line then stays in place, but it really should provide an infrastructure to make sure that a central line can be placed sterilely and that maintenance is appropriate. And I think stewardship should provide the same kind of structure for clinicians to make sure that you know what kind of antibiotics are available, what the local susceptibility patterns are, what may be appropriate, and just reminding you about duration and questioning how long the duration should be and checking in. So I think that thinking about it that way, that it's not there to make decisions, but really to provide infrastructure to make sure that we're all working together to treat patients to treat patients well, I think is important to note.
I look at the second part of this question in some ways as a bit of a research agenda. Our colleague Ryan, aside from reminding us of just how entertaining and wise an infectious disease consult can be, pointed out, we're rending garments and gnashing our teeth around this very narrow question about the initial choice of breadth of antibiotic when we're seeing a patient who's going to be under care for, in some cases, weeks in critical care, in the hospital, and post-acute care. And for all the attention we give and this perceived split between disciplines on this, which I think we're trying to argue is maybe not as great as might seem, we have so many unanswered or partially answered questions about elements, those who are in the prior session, understanding the pharmacological influences in terms of how we do this. And we've got some good early work on that, but which of the patients that really benefit from continuous dosing? What's the incremental risk associated with that first dose of antibiotic? In essence, your question, Mitch. Because again, it may seem like little downside, but maybe with a greater understanding, we can know which of the patients are at highest risk for renal dysfunction, which of the patients at highest risk for Clostridium difficile. Answering and turning our attention away from this singular point, which we may not get additional data to put at ease the clinician at the bedside, but to actually understand how we can take a more thoughtful approach to de-escalation, I think pays enormous dividends going forward, and no more so than for the broader spectrum of resistance epidemiology. So I think that's an important, maybe the most important question we talk about, and that folks here can take away and think a little bit more about.
I interpret your question as how do you make the correct choice quickly? And so I go back to trying to have a system in place that facilitates that so that the clinician can be successful. And so part of that, again, goes back to making sure that you've got something that allows for viral detection, something that allows for an order set that is got multi-stakeholder involvement so that whatever you're doing at 2 p.m. is the same thing that you're doing at 2 a.m. So those are the important pieces, I think, from my perspective.
Hi, I'm Tony Gerlach. I'm a surgical ICU pharmacist in Ohio. And thinking about this, I think we also sometimes miss the point. Common things are common, and uncommon things are uncommon. Most patients don't come in without a history of MDR Pseudomonas that have never had it before, correct? So I think it's our due diligence, one, early on for the ED. What is their history? What are they saying? You need computer systems to see all their microbiologic cultures through the whole hospital stay, one. And two, since I deal a lot with intra-abdominal infections, I think the paper that just came out by the Stop It group, MRSA is not a problem if you haven't been hospitalized, and it's commune-acquired. We need to stop it. Vancomycin or vancomycin for all is just a bad decision. Any comments on that?
I would just add to that understanding, and that to me, that's also an area for focus, of understanding how we prioritize and what the actual contribution of those risks are to the circumstance. We have excellent prediction models in a number of areas in both of our fields, but to really understand what's the risk of CRE, because we can all look at that long list of risk factors, whether for MRSA, CRE, VRE, or what have you, and find something that applies to our patient in some stretch, in some imagination. But how do you actually prioritize? Because some of those are going to be more trivial, whereas others are going to be highly predictive. And if that can inform the kinds of things that Tony's asking about, I think we do well with that.
I think that also brings up a good point, is that when the ER sees a patient and prescribes antibiotics, and the next person comes on and they were started on broad spectrum antibiotics, but they don't have any risk factors, then you're sort of wondering, did the ER find something? Why were they on these broad spectrum antibiotics? Maybe they should stay on. Maybe there was something that I missed in the record. So just knowing the patient's underlying risk factors, I think, is really important to know what they're at risk for and what they're not, because what is started by anybody, the next person picks up, and trying to continue that is difficult, to decide to continue it.
I think Laura brings up a really good point, in that a lot of times the antibiotics are initiated in the ED or continued on the floor. But remember that a lot of times the reason why we initiate broad-spectrum antibiotics in the emergency department is because we have incomplete information. We don't have the patient records yet. Patient comes in at 2 a.m. from a nursing home with one line scribbled across the admission paper that says fever. So it's contingent upon our colleagues to reevaluate those decisions. We all make the best decisions with what we have when we have it.
To the extent that, and maybe rightly so, folks point to the electronic medical record evolving into a compliance tool rather than a documentation tool. This is an opportunity. We tend to teach people that when you see a crazy antibiotic regimen, it's either been done for a really smart reason or really dumb reason, and it's up to you to figure out which of the two it is. And digging in there in the paucity of clinical meaningful data, both objective and subjective data, is a real challenge. So really understanding that and justifying, if not in the actual moment, to be available so that you can actually communicate that on, and recognize that uncertainty breeds breadth of coverage, to your point. And so as more information comes in, we're doing something wrong if our regimen doesn't become more refined.
Any last questions and comments on this? All right, let's move on to our last question. And we're moving into something more practical, and hopefully ending on some strong suggestions of really how to marry these two important initiatives. And so the last question is, what are the practical and lesser-known benefits of a robust antibiotic stewardship program?
Okay, I'll start. We come back to, and Laura already mentioned the safety issues. Maybe we can expand on that a little bit. I'd like to point out from a health system perspective 2 very big advantages. In many ways, individual specialties and discipline have become better and better at designing kinds of order sets and critical pathways for a breast reconstruction patient or for a sepsis patient. Where we haven't really cracked the seal as broader American medicine, at least, is how do we actually develop these interdisciplinary programs? And I think stewardship really offers a chance to look forward and to say, here's a way where we can come together, again, away from the bedside, and arrive at practice that might be seen as somehow constraining, but we'd rather frame it as removing unnecessary variation and doing that together. And stewardship seems to be a good anchor. It's a good anchor because by the attendance here, people are interested in understanding about judicious antibiotic use. It has all kinds of regulatory implications coming forward. But I think it can become the linchpin of how we broaden out to other interdisciplinary practices. And while we start with antimicrobial stewardship programs, there's certainly room for other antimicrobial and treatment classes. The second piece, we don't need to go into it more deeply, is it gives a chance, when you talk about these other benefits, to put stewardship in the framing of changing reimbursement, how we think more holistically about our patients, their care, the expense around their care. Because some of the benefits of a stewardship program go long beyond what might happen in the first couple of days of hospitalization, but may have dramatic impacts as to whether they're readmitted for toxicity or complications, or if they have partial or incomplete treatment of their initial sepsis. So I just feel like the time is right around stewardship, and I think most of the kind of secular trends seem to point in the same direction.
I agree. I think it's a way, stewardship is an important way to make sure that many different departments are involved in treating patients. But I also think it's really important, especially when you're talking about ICU patients, and we've touched on how complex ICU patients are, and trying to figure out antibiotic regimens and duration. I think that having intensivists involved in stewardship and having leadership involved and using stewardship is really important in setting examples and making sure that everyone is involved in stewardship and understanding why it's important and the recommendations are followed, I think is really important. The other area that I think of as an interesting place that stewardship is kind of moving towards too is assessing allergies and how we assess allergies and what is a significant allergy to a patient. I mean, as an ID physician, I often get consulted because a patient has an allergy and they are in some elaborate antibiotic regimen that you have to figure out what the allergy is, and it turns out that they didn't actually have an allergy. So I'm thinking helping to assess allergies and figure out what's appropriate and what's a true allergy, and even providing guidance for physicians to figuring out what is a true allergy or not, I think could be important also to stewardship programs. And some programs actually do allergy testing on patients. So I think that's another realm. And the last thing I just want to point out is that the session before this was, I think many of you were there, was showing how complicated it is choosing antibiotics in patients that are renally impaired and figuring out what the dosage can be. So I think that stewardship really provides an important resource for clinicians to make sure that patients are receiving the right dose depending on what their renal impairment is, hepatic impairment. I think that is difficult for clinicians to also stay on top of. So making sure that stewardship is providing that infrastructure and guidance, I think, is also an important area as well.
So I would say that the issue with resistance has been around for a long time. I mean, when Fleming had his acceptance speech, his Nobel Prize acceptance speech, he then said he had concerns about resistance, and we didn't really heed that. We have intensified warnings now, which I think that we have to take under serious consideration. And I think that needs to revolve around making sure that we're not treating viruses, doing our viral PCRs, using our antibiograms, but also educating patients and their families about why they're getting or not getting the regimens that they are. And then the final thing would be, this is an important national program, and it is important for us as we're implementing this in our local hospitals that we're doing it in a way that helps physicians take better care of patients, that the process is clinically effective as well as time efficient, so that physicians are not, clinicians in general, all clinicians, are not being taken away from the bedside. And so part of that is trying to create the process, but the other part of that is our responsibility as bedside clinicians to go back and tell whoever is doing this, which in my hospital is me, whether or not it's working, right? I mean, we need to know if it's working, if it's not user-friendly, what we need to do to make it better. So it requires talking, communication, and that needs to go across service lines.
And just to add that point, the other thing I think is important about stewardship is also it can act as a liaison between the microlab and clinicians. I think understanding reports and incorporating new diagnostic tests and how that's incorporated into the hospital, I think is an important role for stewardship as well.
So I guess that I want to open it up now, but I guess the question I would ask the panel and all of you is, what are the obstacles? What are the biggest obstacles you experience? Because sooner or later, you know that CMS is going to turn antibiotic stewardship into a pay-for-performance. So we're going to be on the line for that as well. And I just would like to hear, what do you think are the most common obstacles that prevent good stewardship programs? Joe, you want to start?
Should I ask a question or wait for that?
No, go ahead.
So Joe Carcillo from Pittsburgh. I have two questions in terms of a robust antibiotic stewardship. The first, I'll give them both. The first is, emerging infectious diseases generally come from animal reservoirs, and the society does have veterinary medicine. I'm not a veterinarian. So what is being done to make the antibiotic stewardship program more robust by limiting the pouring on of broad-spectrum antibiotics in animal husbandry, which is a far greater source of resistance than patients in the severe sepsis or septic shock campaign spawning resistance. The second question is, where are we in the IDSA and the CDC at thinking about using biomarkers such as CRP to procalcitonin to add that to the antibiotic stewardship program as indicators for reducing antibiotic use safely, not necessarily for starting, but reducing and narrowing? Thank you.
I'll start, and then maybe Laura can continue as well. I think the point about feed animals and agricultural use is an important one. And there's a spectrum, I'll remind, that goes everywhere from what you observe to be one end of the kind of the sharp end we're talking about today of the critically ill septic shock patient, and the other end being the livestock. In between, there's still a whole lot of human medicine that we're not talking about that I would still, we probably would have less of a draw talking about antimicrobial utilization in catheter-associated UTIs, but in my hospital, I would see that as a more pressing issue than I do around the septic patients. I think globally, to the extent that most stewardship programs, and again, we can get the CDC perspective, but from an IDSA, the membership is looking at, for the most part, organizational based, so provider organizations, state health organizations, and of course CDC members as well. And so it's a little bit out of scope in terms of thinking about that. And that's a real hazard, a real challenge. That said, some of the federal work that has been underway, the President's Commission, others, we don't know what the status of that going forward will be, but is aimed to look at a broader perspective around stewardship in general. But I think I'm glad that you brought it up, because to let that go by without mention is, I think, a disservice. To the second point, or to the point about the, well, actually, let me stop there and maybe turn to that. Seems like a good place to turn to you and get some advice.
I agree that I think we think about stewardship within a hospital and connecting it into the larger world, I think, is important, and I think it's something that we're starting to think about at CDC and connecting with our other colleagues and other divisions that are working on that as well, especially with antimicrobial resistance. And this is something that we're working on now and continuing to work on. But again, it is a good point that we should be thinking about that as well.
And I think just to your point, and you echo, is if all we worried about, the only place we gnashed our teeth was around septic shock patients getting one extra antimicrobial, then we're doing something wrong in national antimicrobial stewardship. So again, I appreciate you bringing that up, but again, just to remind that even within our scope of human medicine, there's a lot of other opportunities where the stakes are less high about maybe getting it wrong or providing too narrow a coverage.
I think for myself, handling the sepsis program, and my colleague who handles the antibiotic stewardship for our hospital system, we're just trying to keep our head above water on that right now. So I'll leave the rest of it to you guys.
Great, please.
Hi. My name is Jamie. I'm clinical pharmacist at Banner University, Arizona Medical Center. And my question is in regards to, well, you mentioned what barriers and obstacles do we have to overcome. And I think the biggest one that we have is our septic patients, not the previous severe sepsis and septic shock, getting those broad spectrum antibiotics, and whether or not you guys also are in agreement with CMS's definition of broad spectrum antibiotics, because we all think Vanco and Mirapenem or Zosyn Vanco, and CMS says ceftriaxone is considered broad spectrum. So is that okay for, how do we overcome that obstacle when the physicians are wanting to prescribe the Vanco and cefepime when the patient maybe really is okay with just ceftriaxone? That's my question.
I think that's a very good point, and I think that just thinking about infections that cause sepsis, so if we think the most common infections that cause sepsis are respiratory infections, and many of these patients may be coming with community-acquired pneumonia, and thinking about what's in the guidelines. I think that's a good point. And I think, again, when you're looking at patients when they're coming into the emergency room or they're coming into the hospital and they're septic, you also have to consider, if you can, what the source is, what their symptoms are, how they're presenting, and thinking about what's appropriate. So I think you have to take that in the context of prescribing antibiotics. And again, if it seems appropriate to prescribe broad-spectrum antibiotics, then yes, then a clinician could prescribe it. But if there's other alternatives and it seems appropriate to be prescribing that, I think that that's important to recognize that you have a reason for why you may not need broad-spectrum antibiotics, especially if you have a suspected source or the patient may not have risk factors, and it may be very appropriate not to give broad-spectrum antibiotics.
Did CMS develop that list with IDSA and Surviving Sepsis campaign? Do you know?
Well, sorry.
Go for it.
I'm not CMS, so I didn't.
Right,
I
and I know nobody here perhaps is. I was just curious.
No, only in the extent that we can respond to things in the Federal Register, which, as riveting as it is not always the most compelling tool to do so. And in general, to answer your question from my standpoint, I sort of cringe, again, at the higher up you go or the farther away you get from the bedside about being very prescriptive around selection of therapy or management of patients. I do get uncomfortable with it. So I think we're still early on in the process, not just in this, but with all of the pay for performance and regulatory, to get to a point which allows for, encourages, and in some cases compels the local decision-making that drives it. Just while you're standing up there, though, too, because you remind me of something that hasn't been said about the barriers that Mitch brought up. There's a workforce issue around this because antimicrobial stewardship, at least part of the expertise, comes from folks who are trained in clinical pharmacy with specialty in infectious disease providers. These are fields that need to expand, need to grow. In many cases, folks are turning to groups who happen to be present, happen to be in the hospital as the ones who might run and help oversee stewardship programs. I would put a plug in, although they could do it themselves very well, for folks who are trained in pharmacy, in microbiology, in infectious diseases. Otherwise, the current trend we're heading towards right now is you won't have infectious disease docs to be on the panel or debate these things with because there is considerably diminished interest in folks going into the field and staying in the field, and particularly in this area. So I appreciate our colleagues from pharmacy who are here today because, again, it's an important partnership and one that, absent being addressed, it's going to create a big, big barrier to getting this done.
From a pragmatic standpoint, make it easy for clinicians to do the right thing. You put a process in place that makes it easy so that we can be successful.
Thank you.
And I also want to mention that after the regulations came out, IDSA and SCCM and I think ACEP and a few other professional societies did write to CMS and advocated that single use in a known organism of a focused antibiotic was appropriate, and then they expanded the list of other broad spectrums, and CMS, in their first revision, incorporated those suggestions.
Thank you.
Last question.
Well, I think the discussion leads well into my question, which is about the role of hospital empiric antimicrobial guidelines. So I'm from Ireland, and every acute hospital has an antimicrobial guideline based on the epidemiology and the patient characteristics that hospital services. So a patient presenting, it's an integral part of our sepsis program, patient presenting with an infection with sepsis or severe septic shock, they get their antimicrobial therapy based on whether it's community, healthcare associated, hospital acquired, the site of the infection on history and examination, and then the patient characteristics, be it allergies or known colonization rates. And then if there are concerns, there's a recommendation that a clinical microbiology consult take place early.
And for me, the expectation that organizations, again, it gets harder because here it's less and less going to be hospital-based. We look at health systems. We look at patients who may not touch the hospital, obviously not in terms of this group in this discussion, but that's a minimal expectation of what should be out there. And to me, that could easily be the basis of expectations from CMS, from other organizations around hospital performance. Because again, it entertains, again, my libertarian streak of saying, yes, here at this hospital, we thought this through. We think this is the best practice. And I imagine you and your colleagues come together periodically to review those to ensure that you're actually staying on track with changes in epidemiology.
Yes, we monitor our antimicrobial usage patterns.
And I think you bring a really good point about sepsis. We talk about sepsis as this one kind of big thing that patients come in. We see them with sepsis and starting treatment. But actually, what are their risk factors? Where are they coming from? Are they coming from a healthcare facility? Are they coming from home? Who are these people that we're talking about, and what kind of infections that they have? I think that's a really good point. Is talking about the epidemiology of sepsis. Is that there may be a lot of things that happen prior to getting into the hospital that may help determine what kind of antibiotics you should be giving and what you should be thinking about in terms of infections. I think that's a really important point.
I think it's important in terms of outcomes because if I have a methicillin-sensitive Staph aureus, I want to be getting flucloxacillin, not vancomycin, and certainly not tazocin.
Yeah.
Thank you.
Great. I think this has been a very important session, and as we said in the beginning, this is just the tip of the iceberg. We've already heard about over and over again the regulations for early antibiotics. We know there are going to be regulations eventually on antibiotic stewardship. So the importance of marrying these two initiatives are more important than ever. And so I appreciate our panelists. We have up here their websites. I would encourage you to go to their websites for further information on barriers and solutions to barriers for appropriate antibiotic stewardship programs. And again, I want to thank all of you for your participation.